Bismillahirrahmanirrahim. With the name of Allah, most merciful and benevolent. Assalamu alaikum, ladies and gentlemen. After thanking Allah subhanahu wa ta'ala, I would like to thank the organizers of this symposium. It's a very well organized symposium. And of course, it's always a pleasure to be here in Islamabad. So, I'm going to talk about disease modification in osteoarthritis, the reality and beyond. So, as we all know, it is an arthropathy of the aging, also known as degenerative joint disease or a wear and tear arthritis, in which there is a progressive loss of cartilage with remodeling of the subchondral bone, aberrant repair in the form of osteophyte formation, bone and bony hypertrophy at the articular margins, and progressive deformity of the joint. So, as we all know, the epidemiology, osteoarthritis is the most common form of arthritis worldwide, uncommon before 40 years. However, the prevalence rises rapidly thereafter, and it is the commonest cause of long-term disability. Premature OA has also been seen, and it is associated with gene mutations that encode collagen type 2, 9, and 11. And we see radiographic evidence of osteoarthritis in the majority of people over the age of 65 and 80% of those over 75. And we all know the risk factors. And any of the 200 synovial joints could be involved. However, the most commonly involved are these joints. And amongst these two, the most commonly involved are the knee, the hand, the hip, and the foot. So this is the knee joint, and we are basically going to talk about osteoarthritis of the knee joint, and we see how what a powerful structure this is. And there's a verse in the Quran, the translation of which is, "We have made your joints strong for you." I don't remember the reference just as yet, but I'll take it out and I'll send it to Dr. Bauer. So when we talk about the global burden of the disease, the prevalence of osteoarthritis being the most commonest form of osteoarthritis, and it affects more than 600 million people globally. The increase in life expectancy and consequently the graying population, as well as high obesity rates, have caused a surge in the disease by about 130%. The prevalence rises sharply with age, with nearly 30% of population above 55 years of age being affected. And when we talk about the gender, the prevalence is significantly higher in women, 60%, because of postmenopausal hormonal changes, anatomical variations, longer life expectancy, all contributing to this predisposition. So when we talk about the disability, it stands as the leading cause of disability worldwide, being the main contributor to years lived with disability. And the high BMI is a very major contributing factor. We see that almost 35.8% of OA-related disability adjusted life years. And there's a lot of regional variation as well. There are significant geographical and socioeconomical variations. The high-income regions, as well as those with a high SDI, which is the social demographic index, such as North America and the Asia Pacific, report the highest age standardized prevalence rates, which is about 8.6. Okay, now the prevalence in Pakistan between 1990 and 1921 and 2021, the prevalence rose from 2.85 millions to 8.49 millions, which is about an 18% increase. And knee osteoarthritis accounts for more than 61% of all new cases, having a female preponderance. And in Karachi, it was seen that two-thirds of the older adults had osteoarthritis. So it is a huge economic burden globally. Driven by the high prevalence, the economic burden of osteoarthritis is massive. Direct health costs about $65 billion annually, whereas indirect health costs amount to $160 billion annually. And these are the results from the West. We do not, unfortunately, have any such data in our part of the world, but we see that the rise is very scary. Total cases are expected to rise by 50 to 90% by the year 2050. So, this is a tragedy indeed, because as it is, this disease is difficult to treat even in the West. And when we talk about our part of the world, there are major obstacles in managing OA in the developing countries. To begin with, effective treatment for severe OA is financially inaccessible for majority of population. Then there is lack of awareness regarding early OA and its management. And then patients are misguided and they land with orthopedics, hakims, homeopaths, faith healers, and even pehelwans to whom they go for malish vagera. So, in order to talk about disease modifying agents, we first need to understand the pathogenesis. And we know that there are biomechanical as well as biochemical factors. And the hyaline cartilage is mainly the battlegrounds of the disease. And the older version, that it is simply mechanical wear and tear, no more holds good, because now we see that there is a host of chemical mediators acting. So there is release of inflammatory chemicals like the interleukins. Interleukins activate chondrocytes and the synovial cells. Chondrocytes and synovial cells synthesize the enzyme MMP. These MMPs are primary enzymes which degrade the cartilage around the bones, and hence degradation of cartilage results in osteoarthritis. A little more in detail, we see that it is driven by a vicious circle of low-grade inflammation and cartilage degradation. The, the initiation and progression of OA involves a complex interplay of several categories of chemical mediators, such as the pro-inflammatory cytokines, the interleukins, the tumor necrosis factor, and the next come the matrix degrading enzymes. And then we have the inflammatory mediators, enzymes, and also certain lipids, which involves the cyclooxygenase and the prostaglandin pathways. And then we have certain chemokines, and then we have adipokines, and then we have certain neuropeptides as well. So it is no more a very simple mechanical wear and tear pathogenesis, but it is a host of instruments playing in this symphony. So this is the progression of destruction of the joint, as seen with the naked eye, as well as seen in the radiographs. So osteoarthritis is a prevalent degenerative joint disorder affecting a significant portion of the older population globally. And despite the availability of various non-surgical treatment regimes, their effectiveness is often limited to temporary symptom relief only and lack of disease-modifying properties. And further, we see that osteoarthritis has been categorized into 4 categories: mild, moderate with other health problems, and severe osteoarthritis. So it is only in the first category that we can induce a meaningful disease modification. It becomes difficult in the moderate category and more difficult when there are other comorbidities present. And of course, in severe osteoarthritis, we have a very limited option, and that is the knee replacement. So why is disease modification important? Osteoarthritis is the most common joint disorder and a major cause of disability globally. Considering increasing life expectancy, the aging population is on the rise, and so is the disease. So far, the current therapies mainly reduce pain and inflammation, thereby improving function for some time. Hence, the dire need for an agent which would alter the disease course, slow down, halt, and reverse the structural damage. At the same time, it should be safe with minimal or no adverse effects and also be cost effective. So what is a disease modifying osteoarthritic drug? As yet, it is a class of experimental therapeutics. It is designed to slow down, halt, and even reverse the damage and the structural propagation of osteoarthritis. These drugs are supposed to reduce inflammation, protect the cartilage, and stimulate tissue regeneration, which was degraded, thereby modifying the disease course. So now we come to certain disease-modifying agents, and these comprise of the regenerative therapy, in which we have PRP and stem cell therapy. Then there are certain immune modulators, because there are a lot of interleukins and tumor necrosis factors, etc., involved in the process. So we have immune modulators, in which we have certain biological agents like the TNF and the interleukin inhibitors. Then we have the WNT pathway inhibitors, and then we have certain growth factors, and then at the end we have the gene therapy. So now to begin with, PRP. This is effective in mild to moderate osteoarthritis in reducing, like I have already mentioned, that we can only induce a disease modification in the mild cases, a little bit in the moderate, and then after that, it is not possible to achieve disease modification. So this is effective in mild to moderate OA, reducing the inflammation, thereby the pain, swelling, and stiffness, and promoting cartilage repair. However, it requires early intervention, frequent injections with optimum PRP concentration. So the PRP concentrations vary, and we have to arrive at an optimized level to receive the expected results. So this is a well-designed prospective studies are required to identify PRP responders and optimize treatment protocols. So when we talk about PRP in the treatment of knee osteoarthritis, we have a meta-analysis in which 18 placebo-controlled RCTs, about 2,000 patients were included, and the improvement was clinically significant and influenced by platelet concentration. So this meta-analysis identified the potential of PRP as an effective intra-articular treatment for knee OA. However, it was found that formulations with a higher platelet concentration may be more advantageous. Hence, efforts are needed to select and develop more effective PRP treatments. And then we have the stem cell therapy, in which there is a collection of autologous stem cells from the abdominal fat, harvested, purified, stimulated, and then re-injected into the osteoarthritic joint. Relatively new, but has shown effectiveness in some patients. However, still not approved by the FDA. And these are some of the adverse effects: low blood counts, infection, anemia, bleeding, graft versus host disease, and veno-occlusive disease. So currently, tremendous efforts are being exerted globally towards setting up regulatory guidelines and standards to ensure patient safety. And in the near future, stem cell-based therapies may significantly impact human health. Next, we come to the use of biologics. Although tumor necrosis factor and interleukins play a role in the pathogenesis of OA, however, current guidelines, ACR and Arthritis Foundation do not recommend their use. TNF, a little more time. TNF inhibitors fail to significantly reduce pain or improve physical function, and interleukin inhibitors and cytokines too are not recommended by the ACR as well as the OARSI guidelines. So this is a WNT pathway inhibitor, the loresivivint. It is an investigational small molecule drug given intraarticular to treat osteoarthritis, selectively inhibits certain kinases, modulating the pathway signaling, thereby reducing the catabolic enzymes and the inflammatory markers. It is designed to be administered as a periodic, once or twice a year intraarticular injection into the knee joint. And data from 11 clinical trials demonstrates significantly improved pain and function in patients with a good safety profile. Results from Biosplice, which is the company which is manufacturing, phase 3 also showed that this had led to improvement in the medial joint space width on imaging and follow-up. However, still waiting for FDA approval. Next, we come to a growth factor, which is sprefermin. It is a lab-made form of human fibroblast growth factor. It too is injected intraarticular. It tends to promote the growth of new cartilage by stimulating the proliferation of chondrocytes. In clinical studies such as the FORWARD trial, it was shown to increase the production of extracellular matrix, which builds and reinforces cartilage thickness. However, currently it is still in clinical development and has not yet attained FDA approval. It has mild to moderate side effects, such as arthralgias, back pain, joint side discomfort, etc. Then we come to certain cathepsin K inhibitors. And this is a cathepsin K, we know, is a powerful mediator of bone resorption. And preclinical animal trials show that targeted inhibition can significantly promote joint integrity by inhibiting bone resorption without affecting the osteoclast, hence reducing subchondral bone remodeling and protecting the cartilage matrix. However, still not approved or available for human osteoarthritis. Next, we come to the gene therapy. In this, genetic material is delivered directly into the joint space. This aims at altering the biological mechanisms which cause cartilage degradation and inflammation, targeting inflammation, promoting cartilage repair, and there is regulated expression as well. So, okay, I'll just maybe breeze through this. I've already said the interleukins which block there are certain interleukin receptor antagonists, genes, which block the interleukin activity, reducing inflammation. Then genes encoding growth factors and transcription factors to stimulate the proliferation of chondrocytes, increase the production of extracellular matrix, and then we have regulated expression as well. In this, advanced technologies are used to specifically activate certain therapeutic genes when inflammation is present in the joint. So what is the current landscape? Preclinical models in early phase human trials show promising results in pain relief and safety profiles. Most gene therapies for OA are still in the early stages, and extensive, larger scale clinical trials are required before these become widely available as approved disease modifying therapies. So currently, no disease-modifying agent has been officially approved by the FDA in the clinical trials. None have demonstrated significant efficacy. However, certain promising candidates are currently undergoing rigorous investigations regarding the efficacy, cost, and safety profile. So what is the most effective disease-modifying agent currently? Can anyone guess? It is us. We are the most effective disease modifying agents currently, the healthcare provider. We need to bring about awareness. And if we bring about awareness of this disease, we can very well alter the disease course. We can very well kind of prevent more severe osteoarthritis from developing. And so we did a small session with the family physicians, and it was very well attended indeed. And we had 2 halls full of audience, and we had patients who narrated their sad stories, who could have been treated. And then we had lectures, and then we had a very useful panel discussion, and it was a very interactive audience. So बात ये है कि हमारा schedule इतना busy होता है that we don't have time to educate the frontliners, the family physicians, as well as the patients. Otherwise, अगर हम कोशिश करें तो हमें बड़ी ही अच्छी रिस्पॉन्स मिलती है. वो है ना कि ज़माना बड़े गौर से सुन रहा था, हम ही सो गए दास्तां कहते कहते. So to end, on a parting note, I would like to mention a hadith of Huzur Sallam, in which he says that there is a piece of flesh in your body. If that improves, your entire body is going to improve. And this is your heart. And I'm not talking about the physical heart, I'm talking about the spiritual heart. जिसे कल्ब कहते हैं, जिसकी तस्किए की ज़रूरत है. और हम सब के कुलूब जो है, we are full of spiritual ailments, all of us, which we need to get rid of. So तस्किया नफ्स अगर हो जाए, and what is the mode of acquiring tazkiyah nafs? It is connection with the divine. And in this process only can we attain the qalb salim. With that, I thank you for your time and attention.